we're going to explain the molecular mechanisms of CNI toxicity. We'll talk about some of the histopathological and clinical manifestations of the toxicity. We'll look at some of these various proposed mitigation strategies that are out there in literature. So let's look at the scope of the problem. This is obtained from this study, looking at obtained from some of these registry studies published in 2020, showing that years after the transplant, by 3 years after transplant, almost 50%. These are people who've had surveillance biopsies. By 3 years after transplant, almost half of our patients have evidence of CNI toxicity. These patients are actually not transplant patients. These are not kidney transplant patients. These are kidney transplant patients. So by 3 years out, 3 to 7 years, we're already at 50% with evidence of histological evidence of CNI toxicity, and by 10 years, almost 100% of the patients already have histopathological evidence of the problem. So this is a very prevalent problem, and it's responsible for a lot of the renal allograft losses and CKD that we see in our patients. In terms of trying to find out, because of course we have the issue of allograft transplant glomerulopathy kind of confounds the picture in our kidney transplant patients. So it's hard to decide without doing biopsies how much of this is actually transplant glomerulopathy versus chronic CNI toxicity. So just looking at endpoints like CKD, creatinines, and GFRs, it's really hard to tease apart these two entities, chronic CNI toxicity and transplant glomerulopathy in kidney transplant patients. So in order to do that, we usually look at other solid organ transplants where the native kidneys are still present. This way you can actually separate these two entities out. So these patients do not have kidney transplant glomerulopathy. They only have CNI toxicities. So like this study here is trying to show the effect of this is actually a very good study, almost 70,000 patients. These are non-kidney transplant patients. These are heart, lung, liver, and intestine transplants. And just to show what percentage of these patients end up with CKD stage 4, GFR less than 30%. And looking at these cases, you can see that this is at 5 years, almost 20% of intestinal transplant patients have reached CKD4. There's no transplant glomerulopathy clouding the picture. These are native kidneys. Okay, 18%, almost a similar number of liver transplant patients. 16% of lung transplant. I would have expected the lung and heart transplants to be have worse outcomes because we usually use higher immunosuppression, higher tacrolimus and cyclosporin goals in these patients. But surprisingly, I was surprised to see that the liver transplants had actually more than the lung and heart transplant patients. So they have a very high incidence of chronic CNI toxicity, even at 5 years out. So 11%. Okay. So even though maybe 50% of them have histological evidence of it based on the previous study, already like 20% of them, maybe half of that number, probably already have progressed to CKD stage 4. The others may not have really reached that stage yet. So this is just to show the prevalence of the problem that we're dealing with. And among those patients who develop CKD, almost a third of them will eventually progress to end-stage renal disease and will require either, in these cases, will require kidney transplant or require a retransplantation in cases of kidney transplantation. So this is a very widespread problem. So unfortunately, CNIs are a double-edged sword that we're having to deal with. They're good for immunosuppression, but they will they are nephrotoxic in their own right. So this is a double-edged sword that we have to deal with in terms of managing our patients. So we've been on the lookout for alternatives to calcineurin inhibitors. Unfortunately, the options that we have are not very good at this stage. Nothing at the moment can replace them. There's a new medicine called belatacept that has come out. I think Dr. Al-Qadan presented a talk about it maybe a few months ago, about belatacept in particular. So very effective. Unfortunately, it has to be administered intravenously every month. Very expensive. So I think a 250 milligram vial costs about $1,000, and each patient needs about 2 vials on average. I think it's like 5 milligram per kilogram dose, and it's each vial is 2. So you're talking about $2,000 per dose per patient, and it's a monthly dose, and it's also associated with higher rates of acute rejection compared to the CNI-based regimen. So belatacept is kind of reserved for those patients who have who have evidence of severe atherosclerosis and have severe donor disease. So those are the cases that we kind of, or patients who are unable to tolerate CNIs for whatever reason or have compliance problems. These are the patients that we will give belatacept to. mTOR inhibitors, actually, there was a lot of hope when they came around. Unfortunately, they're nephrotoxic in their own right. They cause podocyte injury and podocyte effacement and proteinuria. So they have high rates of that problem. Also, in the immediate aftermath of the surgery, they cause delayed wound healing and dehiscences and lymphoseals and can cause graft dysfunction in the postoperative period. So they're especially in the immediate postoperative period, they're not really an option. And they also have acute rejection rates are higher compared to CNI-based regimens. So at this point, we're kind of stuck with CNIs as the cornerstone of our management, despite their nephrotoxicity. Okay, so I'm going to do a deep dive into how they work, and then that will kind of give us an idea about the mitigation strategies that are being proposed. So what is calcineurin? First of all, what is calcineurin that we are inhibiting? So it is an enzyme, it's a serine threonine phosphatase. It's located it's very ubiquitous actually. It's present in many cells in the body. It's involved. It's all cells that require calcium cell signaling. It's part of the cascade of calcium cell signaling. So it's not involved only in lymphocytes. Actually, it's present in many cells and it's involved in. So that's why the side effects of calcineurin are very widespread, and they kind of hits widely, hitting many organs. So this is how calcineurin activation operates. So usually there's a transcellular ligand present in the cell membrane. So you have something that attaches to the ligand and stimulates the whole cascade. So for example, we have in the cases of lymphocytes, we have the T cell receptor meeting the MHC receptor in the antigen presenting cell. And plus you need your signal 2 as well. So these two, when they come together, that triggers off the process. So that causes calcium influx from the calcium channels. This binds to a molecule called calmodulin. This is it's a calcium activated enzyme. Calcium binds to that calmodulin. This then binds to our calcineurin, which is the target of our medications. So when activated calmodulin binds to calcineurin, then calcineurin becomes activated and it starts to dephosphorylate nuclear factor of activated T cells. And these are actually, it's not one molecule. These are a whole family of molecules, and there are different ones in different cells. And although they are called nuclear factor of activated T cells, they don't only work in T cells. This is where they were first identified, but they work in many different cell types. And there are a whole slew of them. They're different ones. They actually have different NFAT C1, C. There's a whole nomenclature for the different ones. And this actually makes its way into the nucleus, and it stimulates the transcription of different biomolecules depending on the cell organ, depending on the cell and organ involved. So this in general is the cascade that in general how calcium cell signaling works, and that's where calcineurin fits into the picture. So here's another depiction of the same process. So you have a receptor, You have something binds to the receptor. So, for example, angiotensin 2 stimulates the ventricular hypertrophy also through this mechanism. So it binds to the receptor, and then you have secondary messengers like RAS. These are second messenger molecules that may get activated at the same time. RAS, RAC, PKC, and then you have like inositol triphosphate is also released. This activates opens the calcium channel, allowing an influx of calcium into the cytosol of the cell. In a combination, these two acids, so calcium binds to the calcineurin and activates nuclear factor of activated T lymphocytes. So these make their way into the cell, and then they cause the transcription of the different factors depending on the cell type, like we just said. So here I just showing a depiction of the process working in the T lymphocyte. So we have here's the activation of the ligand. Here our ligand is the CD3 CD4 receptor, the T lymphocyte, the T cell receptor, binding the MHC receptor in the antigen presenting cell, along with signal 2 here. When you have this cross linkage occurring, then you get the calcium being released. Calcium channel opens up, calcium being released. Calcineurin is activated. NFAT is dephosphorylated and is activated goes into the nucleus and stimulates the production of interleukin 2, which is how the T cell is activated. Okay, so here are other cell types that also use this calcium-calcineurin cell signaling. For example, endothelial cells. Okay, in these cells, the synthesis of nitrous oxide synthasase. So the production of nitrous oxide is catalyzed. Nitric oxide is released from arginine using calcineurin. T lymphocytes we just spoke about. In the nervous system, so there's some molecules like GABA is production is controlled by. So a lot of the excitatory and inhibitory neurotransmitters are produced using calcineurin as a second messenger in their signaling cascade. So this is why you get neurotoxicity associated with the administration of calcineurin inhibitors. Commonly, we see tremors, sleeplessness, insomnia, and even higher center problems with memory, even psychosis. We've had a patient who became frankly psychotic on the floor after being started on calcineurin inhibitors. So even higher functions are affected. So it impacts the nervous system very commonly. A lot of our patients have resting tremors, especially in the first months after the transplant. So even ventricular hypertrophy. So angiotensin 2 causes ventricular hypertrophy through calcineurin. So I was reading about, could calcineurin be used to treat ventricular hypertrophy? Apparently it can, but the doses needed will cause kidney failure. So it's not. So calcineurin cannot be used to treat ventricular hypertrophy because you will lose your kidneys in the process. So, but the mechanism is through calcineurin as well. The ventricular hypertrophy triggered by angiotensin 2. Also in skeletal muscle, controls the kind of the fibers in the muscles. In the renal tubular cells, the TRPM6 channel in the distal convoluted tubule, which handles magnesium, is also controlled by calcineurin. That's why when we get calcineurin inhibitors commonly cause hypomagnesemia. Magnesium is primarily passively absorbed the paracellular roots in the proximal and ascending limb of the loop of head, but about 10% of magnesium is actively absorbed through TRPM6 in the distal convoluted tubule. So you lose that with calcineurin inhibitors. And this is why a lot of our patients have hypomagnesemia, and this actually hypomagnesemia is part of the problem. Actually, we'll talk in a little bit. The hypomagnesemia that we see with CNI administration is part of the pathogenesis of the CNI toxicity as well, actually. So then we have keratinocytes. This is why you have hair loss and hair growth, actually. Okay, so hair follicles. So there's a protein called there's a protein that's produced which controls the hair growth and the anagen phase, the growth phase of the hair cycle is affected. So cyclosporin actually causes hypertrichosis, and tacrolimus and voclosporin actually cause hair loss. It's actually one of the reasons why sometimes we have to switch, especially for cosmetic reasons. A lot of we have ladies who lose a substantial amount of hair. We have to switch from one to the other because of this reason. So clinical manifestations are there's an acute form of the toxicity which happens when the levels go high. And then there's a chronic, progressive, usually irreversible form of CNI toxicity, which is the more damaging variety. So acute CNI toxicity, we see it very commonly. A patient has diarrhea, the levels go very high. They develop acute kidney injury. You hydrate them a bit, you hold the dose, and the patients usually recover. The chronic ones are the most insidious and the more dangerous variety, and both are due to a combination of afferent arteriolar vasoconstriction and tubular dysfunction. So we'll talk about the pathogenesis of vasoconstriction and tubular dysfunction in a second. Then there are other rare manifestations. I think I've been here for maybe coming to 5 years. I've only seen maybe 2 cases of thrombotic microangiopathy as a result of CNIs, and this is due to the cause is not clear, as there's no studies, but it's thought to be due to endothelial damage caused by because you have a nitric oxide synthase inhibition. So you have the deficiency of nitric oxide. You have accumulation of reactive oxygen species in the cells due to mitochondrial toxicity. So you have a lot of reactive oxygen species in the cells, as well as the vasoconstriction. These all three conspire to causing endothelial damage, which seems to trigger this. This is the theory. We have no controlled studies to prove this. Anyway, so the CNI-induced vasoconstriction. So this is in a rabbit. So you can see clearly the electron micrograph shows the vasoconstrictive effect of CNIs. So what is the mechanism of the vasoconstriction? So it's a multifactorial problem. So you have a combination of RAS activation due to increase of aldosterone and angiotensin II. You have vasoconstriction, and you also seem to have sodium retention. I think that almost like a Gordon syndrome-like symptom, where you have like the sodium potassium channels and the distal tubules there's an increased activity as well. So there's increased sodium retention as well. So you have that seems to happen as a result of CNIs. So they tend to and they cause vasoconstriction as a result of angiotensin II. Also, endothelin 1 and thromboxane, both of them are upregulated. So the increased expression of these two. These are both potent vasoconstrictors. And then you have the issue of nitric oxide deficiency. So you have decreased synthesis due to decreased nitric oxide synthase. And also hypomagnesemia also causes increased nitric oxide. So these all conspire to increase the vasodilatation. Also, there's increased sympathetic activity. Also, hypomagnesemia seems to aggravate this more. So we do. I don't know. So sympathetic activity is one of the factors. We do notice that patients who have native kidneys, where the nervous system is still intact, versus patients who are denervated, who have kidney transplants from deceased donors or living donors, where the kidney is actually denervated. So when we do the transplant, we don't attach the nervous system, of course. So we do notice that the patients who have native kidneys tend to do worse. This is just anecdotal from my end. I can tell that we seem to think that maybe the presence of the innervation makes things worse, because this may be a factor because sympathetic activity is still intact, so this may contribute to the vasoconstriction. So, but there's no studies to prove, but this is just from. But on the other hand, the patients like who have heart transplants and lung transplants, we do use higher doses of CNI, so that may be a factor. But this is really something maybe to look at maybe in the future. So sympathetic activity, so intact nervous system will cause increased sympathetic tone and contribute to the vasoconstriction. Then we have increased reactive oxygen species due to the low nitric oxide, and also due to the mitochondrial toxicity that occurs, and this also causes the endothelial dysfunction and contributes to the to the problem. This is a nice study that I found. I thought I'd share it with you. So it shows that the sensitivity of the kidney to vasoconstriction is intrinsic to the kidney. So it seems to be more a kidney factors more than the recipient, more than factors in the recipient that contribute to the vasoconstriction. So this is Dr. Wisman and his colleagues. They took 8 pairs of patients who received kidneys from the same donor. So 8 pairs of patients, so 16 patients in all. Each pair received the kidneys from the same donor, and he looked at what happens when you increase the dose of cyclosporin in these 8 pairs. And he noticed that 7 of the 8 pairs showed parallel responses. So four of the pairs showed an elevated, both pairs, the kidneys are from the same donor, showed the creatinine elevation rose in a similar percentage, whereas 3 pairs showed no change. So 7 of the 8 showed the rise. The rise is parallel. So 4 of the kidney pairs were sensitive to cyclosporin increases, and 3 of them were not. So it's clearly that there's something intrinsic in the kidney that makes it more susceptible to vasoconstriction caused by CNI. So this was the conclusion of the study. So this was an interesting. So it appears that it's more an intrinsic kidney characteristic that makes it more sensitive to CNIs than it is the recipient himself. Okay, so apart from the vasoconstriction, so vasoconstriction is one of the mechanisms. Then we have direct tubular injury to the tubule through different mechanisms. So CNIs are metabolized in the proximal straight tubules, and they cause mitochondrial toxicity. They cause damage to the electron transport. The electron transport chain is impaired. They have impaired ATP production and decreased NADPH production. This leads to high reactive species circulating in the cell, causing oxidative stress. This also causes damage to the endoplasmic reticulum. Causes so you see isometric vacuolization. So these are vacuoles in the cytoplasm that are one of the features that you see in CNI toxicity. So these are different from the isometric vacuolization that you see in causes of osmotic injury, like patients who receive hetastarch or IVIG or mannitol, any cause of these osmotic injuries to the kidney. You see isometric vacuolization. So those are usually lysosomes containing the large molecules that you gave. So these molecules are taken up into the tubules, and then they're taken up into the lysosome, and that's what you see as those are the vacuoles that you see in those osmotic injury cases. So in the cases of CNI toxicity, these are actually dilated endoplasmic reticula as opposed to lysosomes. So in lysosomes, you do get some calcifications in the lysosomes. So you do see some scattered calcifications. So these are just lysosomal lysosomes that are enlarged and with microcalcifications. So as a result of this, you get tubular damage and impairment of proximal tubular function. So apart from vasoconstriction, we have proximal tubular dysfunction. So like I said, these are the histological features. So we see dilated endoplasmic reticula, and it's clear in the electron micrographs. a swollen and large mitochondria due to mitochondrial toxicity, the microcalcifications in the lysosomes, and as a result of the chronic afferent arteriolar vasoconstriction, you eventually get damage to the cell wall with hyalinosis resulting, and this causes tissue ischemia and eventual the striped fibrosis that we see in the chronic cases. Also, you get the tubular atrophy and glomerular scarring in the chronic cases. And eventually, this is the chronic cases. So here's some images. So here's the vascularizations, isometric vascularizations. You can see them. I'm not sure if they're clear on this image. So you can see them inside the tubules. Here's the electron micrograph showing a dilated cistern of endoplasmic reticulum. And here's the hyalinosis of an afferent arteriole. And here's eventually the chronic cases where you get the classical striped fibrosis due to chronic vascular injury. Okay, so functional consequences. So so like I said, the proximal tubules are injured, so you can get almost like a Fanconi type syndrome with leakage of with sodium loss, glucose, and amino acids leaking to the urine, electrolyte and metabolic acid-base disturbances, hyperkalemia, hyperuricemia, proximal and distal RTAs, hypophosphatemia. This is supposed to be on its own line, and hypomagnesemia is due to the downregulation of TRPM6 channels in the distal convoluted tubule. And you also can get hypercalciuria with hypomagnesemia as well. So these are what are the factors that worsen or contribute to CNI nephrotoxicity? So these are the factors that have been studied, and there are many studies that point to these as being important factors. So these are important targets of mitigation that we could look at. So of course, the higher dose of the CNI, the higher doses, you get more toxicity. This is partly why we see it very commonly in cases where we have to use much higher doses, like heart and lung. Our target troughs are much higher in those cases, so they're more at risk for developing CNI nephrotoxicity. If the kidney itself has organ disease to begin with, has donor disease to begin with, that kidney is more at risk for CNI. So whenever the kidney already is not a healthy kidney, that kidney is already at risk for developing CNI nephrotoxicity. So an older kidney, a kidney that has been injured by prolonged ischemia times. So the kidney has either warm or cold ischemia times before the surgery. So the kidney has already been injured in the process of the transfer of the transplant. If the kidney itself has atherosclerosis in the initial biopsy that we do of the kidney, so that kidney already is a diseased kidney. So these diseased kidneys usually have a very poor outcomes and are less able to tolerate CNIs. So these are the kind of organs that we look for and try to put them on belatacept and avoid putting them on CNIs to begin with. So these cases, these are the kind of interventions we do to try to avoid CNI toxicity by selecting the cases that we can avoid using CNIs on. Of course, like concomitant use of nephrotoxic drugs, that's self-explanatory. Also, there are a lot of studies that show that salt depletion and diuretic use, so these worsen the vasoconstriction, and they also cause, like diuretics cause worsen the hypomagnesemia, which exacerbates all the problems that we spoke about. So salt depletion and diuretic use. Drugs that inhibit cytochrome P453A45, these of course boost the levels of your CNIs, and using them, even if you can convince yourself that, for example, you're going to put a patient on diltiazem, which will raise the level of your CNI, and then you're going to adjust the dose down. Patients are not 100% compliant with their medications. So even if you're going to keep the patient on a CNI boosting drug, if the patient is even misses a few doses here and there, or he fails to fill the medication, then you're going to wind up with a big problem. So if somebody is on diltiazem and is relying on diltiazem to boost up his level of CNI into the therapeutic range, if for whatever reason he's unable to continue his diltiazem, then his levels are going to fall. Then you're going to wind up with not CNI toxicity. You're going to wind up with a rejection. So we usually like to avoid using these medications, even though in theory you can readjust the dose of your CNI around that drug, but it's safer to avoid doing that. Also, drugs that our CNIs are also apart from renal metabolism. There's also an efflux pump, the P-glycoprotein efflux pump in the intestine, which also is involved in getting rid of the CNIs. So drugs that inhibit this or inhibit this pump, or actually compete with excretion of CNIs through this pump, can actually cause higher levels. For example, statins. A lot of statins do that. So especially with cyclosporin. So we can actually wind up with rhabdomyolysis if you give, for example, Lipitor to somebody on cyclosporin. So we kind of limit it to pravastatin and fluvastatin to avoid this problem. So drugs that inhibit the P-glycoprotein efflux pumps or compete with the excretion of CNIs through this pump mechanism. And then patients who have genetic idiosyncrasies in their cytochrome P45, or actually cytochrome 3A45, or their P-glycoprotein efflux pump. So these patients metabolize CNIs differently. So when you give them the CNI, they wind up with they either are rapid metabolizers or slower metabolizers. They can actually wind up with abnormal levels of these CNIs. So these patients run into problems, very, very commonly run into problems. And these are patients that we have to usually try to switch them to a safer alternative like belatacept or an mTOR inhibitor. So these are the identified factors that can be actually worked on to try to mitigate the chronic CNI toxicity in patients. So mitigation strategies. Okay, so let's look at the actual CNI itself. So comparison between tacrolimus and cyclosporin. Are they the same? So cyclosporin was the first one used. Tacrolimus, when it came along, proved to be safer, causes less CNI toxicity, and also had a better rejection profile. Or in other words, it had less allograft rejection compared to cyclosporin. So this is actually why tacrolimus actually wound up as our first-line drug. So this is the ELITE Symphony study. It's from back in 2007. So they had 1,645 kidney transplant recipients. They were randomized into one of these 4 arms. So there was a conventional dose cyclosporin, where eventually you wound up with a target trough of 100 to 200. Here's the low dose cyclosporin, which is we aim for 50 to 100 nanograms per mil as your target trough. And then there's the low dose sirolimus, target trough is 4 to 8, and low dose tacrolimus, where the target is 3 to 7 nanograms per mil. So the endpoints of the study were GFR at the end of the first year and at the end of 3 years, and it showed that the study showed that the low dose tacrolimus group had the highest calculated GFR compared to the other 3 groups. So let me see here. Just measure that. Yeah, so 65 compared to 57 to 60. 3 years, 69 compared to 64 to 60. So these are significant differences that were seen at 1 and 3 years. And also the tacrolimus-based regimen also was associated with the lowest allograft rejection and the highest allograft survival rates. So even though the tacrolimus dose was lower, it proved to be more effective than cyclosporine. So tacrolimus actually went out and is now used as the first line of treatment in almost all programs. And there have been a lot of studies. These are difficult studies to do because you're trying to avoid precipitating a rejection. So trying to get the lowest. The goal is to try to get the lowest CNI dose that is effective immunologically, but does not cause trying to find the lowest dose that is effective immunologically without so you don't want to precipitate rejection, but you want to find the as low a dose as you can get as possible. So Caesar study looked at compared to low dose cyclosporine compared to standard dose cyclosporine, and it found that at 1 year the rejection rates were similar at 6 months when they compared the low dose versus the standard dose cyclosporine. So actually, we have so our target trough actually in our group in our hospital is about 100 to 150, I think 100 to 200 as it's actually still in our protocol. I think many of us have already started going to the lower dose cyclosporine target based on this study. So the rejection rates were similar at 6 months. So the idea is we're all trying to minimize our dose of cyclosporine to try to hopefully reduce the rates of chronic CNI toxicity. So a lot of these studies are starting to come in and trying to gradually find out safer and safer lower doses. And eventually this may be actually patient specific. So one dose may not fit all patients. So some patients may have weaker immune systems, right? So elderly patients may not need as high a target trough as a young African American male, for example, who need higher doses. So eventually we may have to tailor make our target trough to an individual patient, and hopefully we may come to the point where we're able to assess the strength of an immune system of a particular patient, and then tailor make our target trough, hopefully to get as low a dose of CNI as possible in an individual patient. Okay, so are there any therapeutic strategies, prophylactic therapeutic strategies out there to try to mitigate this problem? So we have a lot of animal studies out there. And there are, of course, the targets, of course, are now that we have a good idea of the pathogenesis of the problem. So we are looking at factors that will try to undo the different the different causes that we've just outlined. So vasoconstriction. So calcium channel blockers have been found to be effective in rat studies. Of course, they block calcium channel blockers, including the calcium channel blockers on the T lymphocytes, by the way. So they do have so calcium channel blockers actually do have anti-inflammatory effect, by the way, because of that actually. So they do impair lymphocyte function because they do prevent calcium influx. And they also cause they will reduce the vasoconstriction that we see in the afferent arterioles. So that was the hope, that they would cause the reduction of they minimize the afferent arteriolar vasoconstriction, and thereby hopefully reduce the rate of CNI toxicity. This was the hope. There were some studies in the 80s that appeared to that appeared to show benefit in human trials. These are very weak studies, I'd say. So this is what kind of prompted people to look into this area. But unfortunately, these studies are very small. They have very small number of patients, and they don't look. We don't have any long-term studies. Unfortunately, you can't find any long-term studies that looked into the effects of calcium channel blockers. So there's a study here in the 90s that looked at diltiazem. Diltiazem, of course, is a very bad choice because of course it causes it boosts the level of CNI, so it can cause that effect of it's one of the worst calcium channel blockers in terms of its effect on cytochrome P450 system. So at 2 years, there was no difference between groups in terms of the endpoints were blood pressure, plasma creatinine concentration, and the number of rejection episodes or frequency of graft loss were similar in diltiazem versus placebo groups. Studies that looked at nifedipine. So this is actually a good study, but the numbers are very small. So the 14 and 11 patients randomized. 14 patients in the nifedipine group versus 11 patients in the lisinopril group. And these patients, they actually measured the blood pressure. They measured the GFR using nuclear scans, actually. So they would see the patient every month, and they did several nuclear scans to see if there's a difference. So then they didn't just depend on eGFR. They actually did nuclear scans, technetium DTPA scans to measure the GFR. And they followed the patients up for about 1 to 3 years. And no difference in blood pressure, GFR, or plasma creatinine concentration. But these are all short-term studies and very small numbers. Here's a study that looked at nifedipine versus no calcium channel blockers. It's a retrospective study which had 58 patients. No difference in rejection rates. Blood pressures were similar between the two groups at 1 year and at 5 years. And the mean plasma creatinine level at 1 year and 5 years showed no significant difference. So this is actually Dr. Ponticelli from the Ponticelli protocol. This is actually his study from Dr. Ponticelli, the famous Dr. Ponticelli from the Ponticelli. So this is his study. So diltiazem, nifedipine, as yet we don't see any evidence of them working. However, other calcium channel blockers seem to be beneficial. So there's a weak effect that was noted in nitrendipine. So 100. This is this is two groups. Nitrendipine was so 109 patients were in the normotensive group, and 146 patients were in the hypertensive group of patients. So because they had to use different doses of nitrendipine. So 10 milligrams BID in the hypertensive patients, and 5 milligrams BID in the normotensive groups. And both of this, they compared nitrendipine to placebo in both of these groups. So and at 2 years, there was a slightly lower creatinine, and this is significant. It was found to be significantly different in the hypertensive group. So 1.68 versus 1.8, and this is at 2 years. So it is a short-term study, and the difference is very small. Not sure how clinically significant, like 1.7 to 1.8 is. But it was statistically significant, and it would have been good to see how, if this study had been continued for longer, if this difference would go up. So, but there did seem to be some sort of effect with nitrendipine in this study, published in the 90s in the Lancet in 1999. And this other calcium channel blocker, lasciddipine versus placebo, this had showed a stronger effect. 131 patients randomized to lasciddipine versus placebo at 1 to 2 years. Allograft function was significantly better in the lasciddipine group. Okay, so 50 versus 43 at 1 year, lasciddipine versus placebo, and 50 versus 42 at 2 years. So calcium channel blockers maybe, but we need bigger studies. We need bigger studies in order to get a better idea of how effective these are. But so there seem to be indications that calcium channel blockers may be, especially these two groups. So basically, this is an area that needs further research. And actually, to be honest, this whole area is actually woefully under-researched, actually, surprisingly. Even though the problem is very prevalent, not much research has gone into this, surprisingly. Okay, and then we have ACE inhibitors. So we spoke about RAS inhibitors being implicated in CNI vasoconstriction. Also, there are studies that show that ACE inhibitors can decrease the fibrosis, the chronic fibrosis that result in the chronic phase of CNI toxicity. So this is where trials on ACE inhibitors have been attempted. So enalapril seem to show a problem, but the studies are small, as you can see. So in April, this is a study done on diabetic patients, and these are not transplant patients apparently. And to be honest, I haven't looked at the study. I actually just saw I looked at the abstract. I couldn't figure out why these these are type 1 diabetics, newly diagnosed, recent onset type 1 diabetics, and who had no prior diabetic nephropathy. And these patients were put on cyclosporin. So either cyclosporin alone or cyclosporin with enalapril. I'm not sure what the clinical indication for giving them cyclosporin was. At 3 months, the GFR remained unchanged in those treated with cyclosporin and enalapril, but decreased by 17% in those treated with cyclosporin alone. So there's a big. So actually, on average, patients who are treated with CNIs show almost like a 30% drop in their GFR on average. When you look at the different studies, you can see almost like a 30-40% drop in GFR in our CNI treated patients. But in this group, the GFR remained unchanged. Those were on analysis. So this is actually quite a remarkable result to show no change with enalapril. 17% reduction with cyclosporin. So ACE inhibitors may be another intervention, but like I said, small numbers. We need more confirmatory studies before we reach a verdict on this case. Okay, then oil, omega-3 fatty acids. Here we're trying to inhibit thromboxane synthesis. If we look at the previous slide, endothelin and thromboxane were one of the two potent vasoconstrictors that are implicated in causing the vasoconstriction. So the hope was that fish oils, by competitively reducing thromboxane synthesis, could diminish CNI vasoconstriction. A number of studies were done, and meta-analyses were done. These are two of the larger ones, and they showed and they consistently showed no clinical benefits actually of fish oils. However, canola oil is another study. This is done in 2005, published in Transplantation 2005. 138 patients randomized into arginine canola diet, 67 patients versus a control group, 71 patients, and the findings here seem to be more promising. So fewer post 30-day episodes of CNI drug toxicity, 9.2% versus 35%, and this is highly significant. And less rejection episodes, I'm not sure how they assess the presence of drugs. They probably looked at surveillance biopsies, and fewer new onset diabetes mellitus as well, fewer cardiac events, fewer episodes of. So this is altogether showed a very good result. But for what concerns us, they seem to indicate that this arginine canola diet was effective in reducing CNI drug toxicity. So this is another area which also needs further research, but this is another study that's out there. Okay, so studies that have shown no benefit. So we have pentoxifylline. Yes. Somebody has a question? No. So pentoxifylline was actually there were animal studies that appeared to show benefit in cyclosporin-induced renal showed in mice, seemed to show a benefit. So this was a study, small number, and of all patients, they picked the worst cases, cardiac transplant patients, which have the highest dose of CNIs. We give them the target trough in those cases almost like 10 to 12. So they have very high CNI doses. So pentoxifylline versus placebo, and in a year there was no difference in GFR or plasma creatinine between the two groups. So no effect, but I think the verdict is still out. We should really try it in other groups of other kinds of transplant patients. And then this is an experimental thromboxane synthase inhibitor. And this is also in mice. This seems to be very effective. Thromboxane synthesis and synthetase inhibitors appear to be effective in mitigating cyclosporine-induced renal vasoconstriction in animal studies. So they tried this in humans. This experimental drug was given for 4 weeks to stable patients with these are patients who had lower GFRs of around in the 40s, for around 40, an average of 45. So these patients were presumed to have baseline CNI nephrotoxicity. I don't believe that they did biopsies to prove it. And although they managed to document an 80 to 90% reduction in the excretion of thromboxane metabolites, so the drug was effective in inhibiting thromboxane synthesis, there was no improvement in either GFR or renal blood flow. So these are two drugs that have showed no benefit in these small studies that have been done. So as you can see, we don't have a lot of good studies actually to build recommendations on. These are very small studies, and we don't have a lot of. So a lot of the studies are mostly in animal studies. So for example, here we have these are a lot of natural products that are being promoted. And these are mostly based on animal studies, so flavonoids, carotenoids, garlic, ginseng. These are things that have been promoted. So these are there is a theoretical. These are all they're mostly antioxidants. So these are very strong antioxidants. And as we saw in the previous slide, the presence of reactive oxygen species is part of the pathogenesis of the problem. So these are all antioxidants. And they're being promoted as potentially useful, but we don't have a lot of. So we have maybe animals, but no human trials confirming the efficacy of these natural products. But they are mostly harmless. They don't interfere with our calcineurin inhibitors, so they don't interfere. So we do advise patients to use them because they are not. There is no, although there's no human trials proving, but they are cheap and they're usually harmless for use in our patients. So summary and recommendations. So based on the above, so these are the summary of ways to try to mitigate the problem. So because we do not have obvious, clear prophylactic medications that we can use, we resort to other avenues. So further research is needed. ACE inhibitors, calcium channel blockers, potentially things like nitroglycerin, right? The nitrous oxide deficiency is part of the problem. Antioxidants need to be looked at. Acetylcysteine, and these are things that need to be looked at to see if there are other drugs that can mitigate. And we need larger numbers, of course, and bigger studies. So these drugs could potentially help mitigate the problem. So from our end, when you have a choice of a hypertensive patient, we should consider like using ACE inhibitors and some of these calcium channel blockers that have shown some effect, like nitrendipine or nitrendipine, for example, and licitipine, for example. These seem to be more beneficial than nifedipine, for example. So potentially these are things that we can use. Dietary, this diet of L-arginine and canola oil is cheap, inexpensive, and advising the use of antioxidant, herbal antioxidants is not going to harm the patient. And so this is potentially something we can recommend despite the low evidence that we have at the moment. We don't have human trials. Well, we do have in the case of L-arginine and canola oil, but needs to be corroborated by further studies. So this is something that we can recommend. We need to find ways to be more efficient in getting kidneys into patients in shorter times. Basically, in other words, we need to lower the ischemic times of the warm and cold ischemic times. That way, we'll make sure that the kidney has less damage when it goes into the recipient. So like I said, a damaged kidney is the kidney that is more susceptible to CNI nephrotoxicity. So finding ways to minimize the damage to the kidney. Identifying patients who have donor disease and keeping those patients and using other treatment options like belatacept or mTORs. For example, patients who are more elderly, patients who have evidence of severe arteriosclerosis in the time zero, allograft biopsy, so the biopsy then on the table before the transplant. Identifying those patients who have genetic polymorphisms in their cytochrome or P-glycoprotein efflux pump genes. So those patients who are more susceptible to CNI nephrotoxicity, need to identify them and put them on belatacept or mTOR inhibitors as their primary medication. So, for example, mTOR, for example, we may want to put them on tacrolimus in the beginning until they get over until the wounds have healed, and then you can transfer. Then you can move them over because you cannot use the mTORs initially because of the problems with wound healing. And belatacept, we can also use it later on. So tacrolimus, we're stuck with using CNIs in the initial phase, and then maybe shifting to mTORs or belatacept later, just to avoid the chronic CNI toxicity in these patients. Of course, we talked about the priority of tacrolimus over cyclosporine. This is already being implemented. We're looking at studies that are coming to try to achieve the lowest effective dose of CNIs, and looking at potentially individual dosing for patients to get the lowest effective dose for an individual patient without compromising immunosuppression. And of course, the avoidance of salt depletion and diuretic use, loop diuretics in particular. Loop diuretics are the problem because they worsen the hypomagnesemia and confound the problem. And as I said previously, hypomagnesemia seems to be worsens all the causes of vasoconstriction that we spoke about before. So hypomagnesemia is a very common problem in our patients. So we're using magnesium supplementation and making sure that the magnesium levels are monitored closely and that they're within therapeutic range is a very important factor in reducing this problem. And to this, I come to the end of my presentation. I hope I didn't go over time.
Thank you very much, Dr. Ibrahim. That was excellent. Both the basic side, the animal studies, the practical clinical side, and also even the natural remedies. That's really great. Thank you so very much. Since we are over time, if you don't mind, I will ask people that have possibly questions from you. They know how to find you, whether through emails or they know where your office is, so they can reach out to you and ask questions, if it is okay with you.
Definitely. Anybody who wants any of these papers, I'd be happy to forward them any of the studies that are there.
Perfect. Thanks again for the excellent presentation. Everyone, I hope you will have a great weekend. I think that the candidates will be having a meeting with Dr. Ruchi. Thank you very much.
Thank you. Bye.
Sure. Bye-bye.